Good morning. Thank you for designing this beautiful IC, Nikunj. Preparation of this talk really made me nostalgic as I was digging into my older surgical videos and photographs. So I completed my MS in ophthalmology from SMS Medical College, Jaipur. Then I pursued my long-term fellowship from Narayana Nethralaya, Bangalore. Why glaucoma? We know that it's defined as optic neuropathy and all, but to look for those subtle changes in the discs and to know those causes of glaucoma really makes this branch interesting for me. Every eye is different. Sorry. And also we know very less about this disease. The only modifiable factor that we know is intraocular pressure. All our treatment revolves around just that. So did my PG, did my fellowship, felt pretty elated. When I stepped out seeking for job opportunities, I got the reality check. It was just the beginning. After fellowship, I was pretty confident in handling those gray areas, when to treat, when to observe, those nightmare reports, which I really found very difficult in my PG days. I got the hold of them, did hundreds and thousands of gonioscopies, PIs, knew how to play with anti-glaucoma medications. Regarding surgery, when to plan trab and the post-operative bleb maneuvers. Okay, everything is covered? I don't think so. Was I actually confident in handling those difficult glaucoma cases independently, especially single-eyed patients, advanced glaucomas, going for valve implantations? I was fortunate that I got an opportunity to work as a consultant at AIOC Sitapur. I really grew as a clinician, as a surgeon, and most importantly, I made some friends for life there. Moving on to the clinical talk now. So just sharing a video here. A routine case of combined surgery was taking my superior rectus suture, and when I started doing peritomy, I realized that there was a partial thickness conjunctival tear in the left bottom of the screen. Anyways, I continued with the surgery. So even though it's a partial tear, you need to repair it for a good bleb outcome. I proceeded with the surgery. After doing the bleb closure, suturing it to the limbus, I closed this tear with a 10-0 vicryl suture with interlocking continuous suturing technique, and this patient did well post-operatively. So how to avoid these situations? Very, very important. Please respect the conjunctiva. Gentle tissue handling is a must. We often use limb forceps for peritomy and other surgeries, but as a glaucoma person, I cannot emphasize enough that you use atraumatic forceps. So just an example here, I'm using Pierce-Hoskin forceps to hold the conjunctiva. Take your time, make a clean nick at the limbus when you go with your peritomy. Being bidextrous really helps. You can use that scissor in your left hand and do a good dissection. Know your instruments, like I'm using a Westcott scissor with blunt tip here, so you know you have minimal bleeding when you do subconjunctival dissection. You go more posteriorly to get a posterior filtering bleb. Pre-operative planning is a must. Please just take a couple of seconds to have a look at the conjunctiva before you take the patient into the OT, whether it's mobile or it's scarred. Just sharing an example here, I was taking this pseudophakic eye, very refractory glaucoma for trabeculectomy. She had a lot of hyperemia, as you can see. And on having a closer look, you can see that even though she had undergone phaco before, but there was scarred conjunctiva. So I had the plan in my mind. I used a higher concentration of mitomycin C, avoided this location, performed a superior trap. And in such cases, corneal traction suture also helps. So it avoids further unwanted manipulation. You take an 8-0 vicryl suture with a spatulated needle, gently take a partial thickness bite of the cornea parallel to the limbus. You can clamp it inferiorly, and there you have such a good view for your surgery. One of the areas of struggle for me, during my institutional training, all my mentors were performing same site combined surgery, so did I. But I often ended up with leaky main ports, which led to poor interior chamber stability, a lot of wound hydration. I was anyways performing temporal phacoemulsification, so I switched to twin site, superiorly trap and temporal phaco, and I ended up with much controlled closing of my cases. As a glaucoma person, we are often concerned about, if we'll have an overfiltering or a nearly flat bleb. So releasable sutures come to our aid here. Just a small video. So this is a 10-0 nylon suture. You are passing the needle just similar to that traction suture bite. Again, the needle is passed through the cornea. It comes out through your scleral flap. All these bites are partial thickness bites. For the third bite, you pass it through the edge of the flap, come out through the adjacent sclera. You have taken 3 bites now. So when you pull the suture, it is important to leave this loop here, because you will take 4 throws and use this loop to tie your releasable. You just trim this end, keep it long so that you can tighten or loosen the suture before your final closure. Check for bleb leak at the end. It's always a good idea whether you have a watertight bleb. And then finally, you just trim that corneal end of the releasable suture and you close the case. So to remove it is as important as to apply the suture. In OPD, just hold the lid with your left hand. Ask the patient to look down. With a 26 gauge needle, you can just take out this loop. Now you have this free end of the suture. Just gently hold it with a plain forceps and wriggle it out. So checking for bleb leak always prior to going for releasable removal. See how gently I'm just giving massage temporal to the bleb area, never on the bleb area, and you have a good bleb. One very important slide, I asked one of my fellows just to share her journey, what were her challenges, and I've actually put up her notes. So this emphasizes that just like any other surgery, you have to know your patient, you have to counsel your patient, you have to be on the same page because you are handling a very difficult disease here. You have to inform your patient that glaucoma is not curable. All the treatment is to save the remaining vision. And patients often compare such surgeries with the cataract surgeries. So please talk about the sequelae, and they might have to come for reprocedures, anti-glaucoma medications in future. It's a lifelong follow-up pattern. Often you have such patients who have really advanced glaucoma, so you have to go for a holistic approach, motivate them for a healthier tomorrow.